Can you hear me? So I will start. Hello everyone, and welcome to this session on staging of early lung cancer using FDG PET-CT. And I thank the organizers for giving me an opportunity to speak in this conference. Now, we all know that all guidelines and recommendations for staging of lung cancer recommend the use of FDG PET-CT. Now, why is it so? Why all the guidelines and recommendations recommend the use of FDG PET-CT? Because if you look at the NCCN guidelines, you can see that across all stages of lung cancer, stage 1, stage 2, or in locally advanced lung cancer, you can see that FDG PET-CT has been recommended as an initial staging modality. Now, the reason these recommendations have come about is because as early as 2002, certain randomized trials were conducted, like, for example, the one published in Lancet, where they randomized patients into two groups. In one group, comprised of patients where the lung, where a conventional workup was done, whereas in other group, PET was added to the conventional workup. So they found that across in two trials, in almost 20% of patients in the PET group, futile thoracotomies were prevented. So that's really in 1/5 number of patients. When PET was added to the conventional workup, there was a change in the intended management. So because of these early randomized trials where PET was subjected in a trial setting, the results were in favor of use of PET for initial staging. So because of these early trials and subsequent huge amount of data, FDG PET has been recommended as a standard imaging modality for initial staging of lung cancer. Now, to just give you an example, if you look at this CT scan of the chest, you can see that there is this peripherally situated lung cancer, eminently operable. But if you look at the whole body FDG PET-CT, you can see that along with the FDG avid lesion here in the right lung, there are these two tiny foci somewhere in the abdomen. Now, if you look at the CT scan, you don't really see any obvious abnormality. But if you look at the PET, you can see that there is this FDG avid lesion. And in the abdomen, you have this subtle peritoneal metastasis, which probably could have been missed on a CT scan. So patient which was T2N0M0 on CT scan, which could have been operated, now becomes T2N0 and M1. And now has systemic chemotherapy has to be given for this patient. Likewise, for patients who are slightly advanced, which are suitable for probably, which are not directly operable, but which are suitable for chemoradiotherapy. There are these several trials where if PET is used in these locally advanced patients, because of the presence of detection of distant metastases in from almost 20 to 40% of patients, there is upstaging, and patients, the intent of management changes from CTRT to systemic chemotherapy. So that's how PET has been very useful in very early, potentially operable patients of lung cancer, as well as patients who are amenable to chemoradiotherapy. So in these settings, PET has been extremely useful. Just a second. Yes, Garima. So I think there's some technical issue with the slides.
Perfect. All right. A very good morning to everybody. And so we're starting off the session on early stage lung cancer. We'll begin with mediastinal evaluation in early lung cancer. I'm Devyani Niyogi. I'm a thoracic surgeon from the Tata Memorial Hospital in Mumbai. Since we're kickstarting the session with this talk, let's begin with what exactly do we characterize as early lung cancer. So according to the AJCC staging, which is the 8th edition that we're currently using, anything that is T1, T2, or N1, N2 is early lung cancer. That means any tumor which is up to 4 centimeters in size or node negative, at the most Hyler node positive. These are the ones that come under early. So if we've already decided that they're early lung cancer on imaging, why do we need to stage the mediastinum? It is basically to detect the radiologically occult N2 and N3 nodes. Lung cancer staging mainly involves these three things. You would have done a tissue diagnosis to arrive at your diagnosis, a PET scan for a whole body staging, and an MRI brain to look for any brain metastasis. After all of this, why stage the mediastinum? So the answer to this question lies in the table on the top left. So first of all, only 15 or 20% of lung cancer actually presents in the early or loco-regional stage. And if you notice the circle numbers on the last column, the survival drops precipitously, almost by half, once the lymph nodes become involved. So the nodal status actually determines the treatment options and the prognosis of the patient. It significantly affects the patient's survival. And despite all kind of staging that we do, 12.5% of the times we are still caught unawares with N2 disease. As you can see the survival curves on the right, the red line is N1 node. The green line, which the survival drops pretty precipitously, is the N2 nodal status involvement. Are there any patients where that much of staging with PET CT and MRI is enough? Can we avoid mediastinal staging? So mediastinal staging in lung cancer is actually a rule. The only exception being peripheral lung tumors, which are in the outer 1/3 of the lung fields, and T1 tumors, that is tumors less than 3 centimeters in size, and node negative at the hilum and mediastinum on the PET scan. So your tumor has to fulfill all these three criteria for us to safely say that no invasive mediastinal staging is required in this case. So why is PET CT not enough? All other cancers, we do a PET scan and that's the end of staging. The reason is, as Dr. Nilendu will also clarify in his talk, that PET CT in lung cancer is prone to a lot of both false positives as well as false negatives. So when we analyzed our series at TMH with lymph nodes with SUV uptake of more than 4, which in any cancer would be considered as fairly significant, in lung cancer, the false positive was seen in 18% of the time. That is, in 1 in 5 patients, we risked upstaging the patient if we only depended on the PET scan for the mediastinal nodal status. The reason for that is India is a country which is endemic for TB and for granulomatous disease. So even the nodes which are affected by granulomas or TB can look as hot nodes on a PET scan and may end up upstaging your patient quite significantly. The other end of the spectrum is the false negative, which is due to the shine through effect of organs in the mediastinum, which all have pretty high uptake on a PET scan. And so you don't end up seeing the hot nodes, which risks to understage your patient, and you end up giving less treatment than you would actually, the patient would deserve. Which is why we come to invasive mediastinal staging. There are 2 ways to do it. One is the endobronchial ultrasound with an endosonography through the esophagus, which is called EUSB. And the second is the mediastinoscopy. So the EBUS is a relatively new kid on the block. It's way less invasive than a mediastinoscopy. It's done under conscious sedation. And all the guidelines recommend it as the initial step in invasive mediastinal staging. If it is associated, you have a pathologist on site who gives you a rapid on-site examination. It improves the accuracy of your EBUS and also hastens the results. It is associated with absolutely negligible complications. Mediastinoscopy is the gold standard for invasive mediastinal staging. It's a surgical procedure done under general anesthesia. You could have a standard mediastinoscope where you peer in through the mediastinoscope into the mediastinum, or what is more done today is the video mediastinoscopy, where the image is projected onto a screen. And the false negative rate, being the gold standard, is as low as 2%, although it is associated with a few complications in 6%. We'll come to that subsequently. So these are the ISLC nodal stations. EBUS and mediastinoscopy can pretty much well assess your levels 2 and 4 on both sides, as well as the subcarinal nodal station 7. EBUS, in addition, can also evaluate stations 10 and 11, that is the hilar and the interlobar nodes. The mediastinoscopy, if you push it a little in front of the left main bronchus, can also get you to level 5. But having said all this, for both EBUS and mediastinoscopy, the blind spots still remain stations 5 and 6. When we put the EBUS scope through the esophagus, we can also access stations 8 and 9. So our true blind spots in the mediastinum remain station 5 and station 6. So this is the genesis of EBUS. These were the 3 seminary papers that came up on this as early as 2004. And if you see the authors, be it Yasufuku or Anima, all of these were thoracic surgeons. So basically, EBUS, though being an endobronchial procedure, was a thoracic surgeon's brainchild. And the early results itself from these centers were extremely impressive. If you see the sensitivity and the specificity, they almost approach that of the gold standard, that is mediastinoscopy, and this was way back in 2004. But the question remains, are these fantastic results reproducible? As with any sonographic technique, even EBUS is operator dependent. It is associated with a significant learning curve, and single center experiences started reporting false negative rates of as high as 20%, which is a very high price to pay when you think about lung cancer. This was shown in a randomized controlled trial, which is called the ASTER trial, which pitched the combination of EBUS and mediastinoscopy on one side, as against surgical staging with a mediastinoscopy on the other. And what they found, that the sensitivity of an EBUS combined with a mediastinoscopy was a phenomenal 94%. And it brought down the futile thoracotomy rates from 18% to 7%. So the ASTER trial was actually the background and the basis for the ESTS to come up with their 2014 guideline, which is still the latest version. So even in 2022, we are following the 2014 guideline, which says that if your PET scan shows no mediastinal nodes, then any one of the 2 techniques is enough for you to complete your invasive mediastinal staging. But if the PET scan shows suspicious looking nodes, you start with an EBUS. If the EBUS comes negative, it is mandatory to confirm it with a mediastinoscopy. So let's see the journey that EBUS has traversed from 2004 till today in 2022. The false negative rates in most centers that are performing EBUS have become better and better. They're inching closer to the gold standard, that is mediastinoscopy. The sensitivity and specificity, especially from some of the series that are reported from South Korea, are 88% and 100%, which are actually better than mediastinoscopy. And they're associated with almost no complications. So it's becoming more and more attractive. One paper that came out recently that we should know about is the SCORE study, which said that a systematic nodal sampling, where you diligently go into each station, check the nodes, and any node more than 5 mm gets sampled, actually gives better results than a selective strategy where you only target the PET positive nodes. So in today's day and age, is a confirmatory mediastinoscopy mandatory? Why not? Because all the studies that have studied this showed that the limited additional nodal MET that was picked up with a mediastinoscopy was actually not that significant. The morbidity was something to think about. Not to mention the treatment cost and the delay, because you're doing 2 procedures only to stage the mediastinum. And the micrometastatic N2, which were additionally picked up by the mediastinoscopy, had a questionable impact on survival. So Bosima is a big name in mediastinal staging. He did a meta-analysis which said that the unforeseen N2 rate was around 9%, whether or not you confirmed your negative EBUS with a mediastinoscopy. Moreover, mediastinoscopy has a 6% morbidity, including recurrent palsies and chyle leaks. And this unforeseen N2 in this 9%, when they followed it up over time, actually had no impact on survival. So you have the MEDIAST trial, which is currently ongoing. It is just about completing accrual, which will help us answer this question with some evidence backing. Can we forego a mediastinoscopy after negative EBUS? But a mediastinoscopy or a VAMLA, that is a video-assisted mediastinoscopic lymphadenectomy, is not completely obsolete. What it helps the surgeon do is it helps them assess the resectability of the nodes. It gives you a very good clearance for left-sided tumors because the arch aorta comes in the way when you try to clear left-sided nodes by a VATS or a thoracotomy approach. The morbidity is acceptable. It's a palsy rate of 2.4% that we're looking at. And the most attractive thing is the surgeon is enough. So we don't have to depend on anybody else or any other procedure to stage the mediastinum. It can be timed at the same time as the resection of the primary if your institution has a frozen section available. So we've seen what is perfect. We've seen the guideline, negative EBUS needs to go for a mediastinoscopy. But how perfect is perfect? So we saw in the ASTER trial that a combination of the two gives us a sensitivity of 94%. But we still got it wrong in 9.6% after doing all this. 7% still underwent futile thoracotomies. People ended up paying more just to stage their mediastinum. They ended up waiting more for their final curative intent surgery. And to be honest, with how many centers in India have an infrastructure that can give you EBUS and mediastinoscopy just at the drop of a hat? Next question, how feasible is perfect? So forget India, let's look at Denmark. Okay, and look at this paper which tried to look at the adherence to these protocols in Denmark. The names that I've circled, again, Mr. Bosima makes an arrival here along with Anima, the biggest names in invasive mediastinal staging. And even in their center, this protocol, this strict mediastinal staging protocol was adhered to only in 19% of the patients. EBUS EUS was an initial staging in 43%. And confirmatory mediastinoscopy was done only in 44%, less than 50%. This is in Denmark, where all healthcare is paid for, all the facilities are available. How can we reproduce this in a country like India? So like with everything else, we need to do a very good balancing act over here. So the way we prefer to do it is pick EBUS when you think that the chance of your node coming positive is high. So you do a less invasive procedure, go improve your nodes positive and send your patient for systemic therapy. But when on the PET scan, you feel that the chances of the nodes coming positive are low, it's best to go in and do a mediastinoscopy, send the nodes for frozen, they come negative, proceed with surgery. So this is the balance that we can find between the two procedures. I'd like to conclude my talk by saying neural stages significantly impact treatment options. There's no doubt about that. It also helps you to prognosticate your patient. So it is something that needs to be done diligently. What you see is not always what you get on the PET scan. So we know that invasive staging is a must. There is no getting around that. It is difficult to be perfect, but in such a scenario, it's best that we be wise and we choose between EBUS and mediastinoscopy, which works best for us and the patient as well. Thank you very much. I'd be happy to take any questions. Okay. All right. I think we're running out of time. We'll get the next speaker on. Thank you.
Thank you, Dr. Devyani. So we'll move back to our previous talk by Dr. Nilendu Purandare, who's a professor and consultant at Tata Memorial Hospital on the role of PET scan in early stage lung cancer. Sir will be joining us again. Sir, over to you.
Thank you so much. Sorry for the technical glitch. Am I heard? And can you hear me? Just show is it.
And slides are audible. Audible and slides are also seen, sir.
Okay, thank you so much. And sorry for the technical glitch. I hope this one goes smoothly. And so, as I said earlier, we'll be speaking on the role of PET CT in staging of early lung cancer. As we know, most guidelines and recommendations recommend the use of FDG PET CT for initial staging of lung cancer. And the reason this has been brought about, the reason why PET CT is a part of standard guideline recommendations in lung cancer is because NCCN guidelines across various stages of lung cancer. If you read the guidelines, they very clearly state that FDG PET scan is to be done in the initial staging workup of lung cancer. Now, what is the reason why PET CT has found its way in the guideline recommendations for lung cancer? Because way back in the early 2000s, now lung cancer was amongst the first cancers where PET was subjected to randomized trials. So there were trials where patients of lung cancer were randomized into two groups. One group, conventional workup was done, which in those days included a CT scan of the chest, and upper abdomen, a radionuclide bone scan, and imaging CT or MRI of the brain. And PET was added to the conventional workup. And so when such randomized trials were conducted, they showed that in nearly 15 to 20% of cases, futile thoracotomies were prevented. And this was mainly because of detection of asymptomatic distant metastatic disease. So because of these early randomized trials, which showed clearly a change of management in the PET group, and the subsequent trials which also showed a clear-cut advantage of PET in staging of lung cancer, PET has been a part of most guideline recommendations. So this is an example of lung cancer. T2 lung cancer, by virtue of its size, looks eminently operable. CT scan also did not reveal anything. So when a whole body PET scan was done, you can see that there is uptake in this at the primary site, but you see these two small foci in the abdomen. So that's the FDG-avid lung cancer, and there are these FDG-avid foci in the peritoneal cavity. So this probably would not have been detected on a regular contrast-enhanced CT scan. So a patient which was staged as T2N0 M0 by conventional staging, which should have been easily operated, now becomes T2N0 M1, and patient now has to be given systemic chemotherapy. Likewise, for patients who, on the basis of conventional imaging, which are suitable for chemoradiotherapy, when such patients are subjected to a PET scan, in up to 40% of cases, because of detection of distant metastasis, the intent of treatment changes from radical chemoradiotherapy to systemic chemotherapy. Because of all these reasons, PET has been a part of standard guideline recommendations as an initial staging modality for lung cancer. So this is an example of a lung cancer, here pleural based, probably eroding the vertebral body. You can see when you look at the whole body MIP scan, you can see these small tiny foci, and these are these tiny deposits in the abdominal cavity. So again, this patient, which probably would have been given chemoradiotherapy because of its closeness to the vertebral body and the costovertebral junction, now because of detection of these systemic disease, has to be given chemotherapy. Now, when you look at T staging, now this is the chart of 7th edition of TNM staging, and this is a bar which tells us about the changes which the 8th edition has brought about. When you look at the T staging, now all possible parameters of T staging can be studied using a contrast enhanced CT scan. For example, this is a centrally situated lung cancer which is encasing the pulmonary artery. So these on the right side and this on the left side. So this becomes T4. That is pulmonary artery infiltration. CT scan very clearly shows it. This patient is unresectable. No need for PET scan. So for T staging, CT scan is good enough. PET doesn't really add any incremental value for T staging. However, there are occasions like this when you have big opacity, you don't know where which part of the opacity is cancer and which part of it is consolidation. So in such cases, PET helps. For example, in this case, there is the central opacity, central FDG-avid lesion here, which you really can't differentiate on a CT scan. And that's where the primary tumor is, and the surrounding opacity is actually atelectasis. So basically, PET can help in T-staging demarcating tumor from atelectasis. So apart from that, for T-staging, PET really doesn't have a great role. So for staging workup of lung cancer patients, PET is superior to conventional workup. And in combination with MRI brain forms the complete staging workup. MRI brain, I suppose, is going to be covered in the next lecture. It changes management in a significant number of patients, from 20 to 30% patients. And PET is an excellent tool to assess response to chemotherapy, radiotherapy, and targeted therapy. Now, looking at these slides, it all looks hunky-dory that PET is fantastic, but it does have its own limitations. PET has its own Achilles heel, which we need to know before we actually use PET-CT in practice. So mediastinal nodal disease remains a big problem with PET. There are both false positives as well as false negatives. False positives is actually a bigger issue, particularly in our country where there is a preponderance of granulomatous disease. So this is the data across Asia as well as Europe and Western countries where PET has been used for nodal staging of lung cancer. And you can see that across all these countries, the negative predictive value of PET for mediastinal nodal staging is very high. But if you look at the positive predictive value, it's a little bit less than the negative predictive value. In fact, it's quite modest. When we looked at our own data at Tata Hospital of around 350 patients, the negative predictive value of our database was also high, upwards of 90%, but our positive predictive value was again modest, so almost around 50%, which tells us that PET really has many false positives when it comes to mediastinal nodal staging. So this is an example of a lung cancer here with FDG-avid mediastinal nodes. This is an example of another lung cancer with mediastinal nodes. Now, one of them is cancer and one of them is TB. On the basis of FDG uptake, it's really very difficult to say which is cancer and which is tuberculosis. So this actually is cancer and this was tuberculosis. So it's very difficult to determine just on the basis of uptake which is disease and which is actually tuberculosis. So for nodal disease, whether it's TB or not, false positive PET remains a challenge. For positive PET, you need some sort of mediastinal staging, be it EBUS, TBNA, or invasive mediastinal staging using mediastinoscopy. For negative PET, for mediastinal nodes, PET has a high negative predictive value. In around 90% of patients, PET, you can predict that there are no mediastinal nodes. However, you can still miss smaller lymph nodes or microscopic disease. And in our institute, we still do EBUS followed by invasive mediastinal staging, even if the PET is negative. Now, there are certain diseases in lung cancer which do not show FDG concentration. For example, small metastatic lymph nodes, ground glass nodules, mucinous lesions, very often FDG cannot resolve. FDG has poor ability and PET can't resolve these conditions. So this is a garden variety lung cancer, very FDG avid. For example, ground glass opacities such as these, which actually harbor disease like adenocarcinoma or adenocarcinoma in situ, PET may not really resolve them, and you have to rely on the CT component. So absence of FDG uptake in a tiny nodule does not mean that it is not metastasis. That's something which we need to remember. There are certain cancers like bronchioloalveolar carcinoma which have a high amount of mucin and hence are acellular in nature, do not show FDG uptake. So this is an example of a bronchioloalveolar carcinoma nodule which does not show PET uptake, whereas this is a regular garden variety. This is how normally lung cancers are FDG avid. But adenocarcinoma in situ or BACs may not often show uptake. So that's something which we need to remember. Pleural effusions also may not show FDG uptake. So this is a FDG avid lung cancer and this is pleural effusion. So if it does not show uptake, that doesn't mean that the effusion is not malignant. Occasionally it can show pleural uptake like this, which tells us that the effusion is malignant. But absence of FDG uptake in pleural effusion does not mean it's not metastatic pleural disease. For brain metastases, PET, there is normal physiological uptake in brain tissue. So there is very poor signal to background ratio, because of which PET can often miss disease in the brain. So lesions which are very small or lesions which are in the posterior fossa or meningeal mets can be missed on PET CT. So for example, this is a PET and this is a fusion PET CT and this is a CT. There is no evidence of any brain metastasis. But if you look at the MR, you can see a very clear-cut metastatic lesion in the cerebellum. So MR is much superior when it comes to brain metastasis. Now, this is an interesting paper which compares the CT era, which was up to the 1990s, and the MRI era which was beyond 1990. It compares these two eras for detection of mets. And as we moved from the CT era to the MRI era, you can see that the number of undetectable brain metastases dropped by 15%, and the number of single as well as multiple brain metastases significantly increased, nearly doubled in the MRI era, which shows that overall MRI is superior to CT scan as well as PET scan in detection of brain metastases. MRI detects more lesions, it detects smaller lesions, detects lesions in the posterior fossa and in the meninges, areas where CT scan is conventionally weaker. In asymptomatic patients, MRI is more likely to detect metastases compared to CT scan. Whereas this difference between CT and MR is less pronounced in patients who are symptomatic because of the presence of brain edema. Symptomatic patients usually have edema, which is even detected on CT scan. And in up to 20% of patients where CT scan detects a solitary lesion, MRI will have multiple brain metastases. So these are two examples where CT scan doesn't show any obvious disease. You can see multiple small metastases in the on the MR sequences. So these are very tiny, small size metastases which CT misses and MRI picks up. So one thing which is a take-home point, that a negative PET CT does not obviate the need for dedicated brain imaging with MRI. Now, so what is the role of PET CT when you have dedicated MRI? What is the role of PET CT for brain metastasis? Now, of late, several centers perform a very good quality contrast PET CT with extended brain protocol. That is, a good quality CT brain is available along with PET. So if a PET scan shows a lesion in the brain, an enhancing lesion on the CT component of brain, in such patients, MRI can be avoided because the patient is already upstaged. So negative PET CT does not rule out brain mets. And if the PET CT is positive, that means you're reasonably sure that there are metastases and MRI can be avoided in such cases. When we evaluated our nearly 900 patients at Tata Hospital, where we essentially compared the extended brain protocol of PET CT with MRI brain, we found that MRI detected metastasis in 12% more patients. That is additional 16% of patients as compared to the CT component of the PET CT. However, the upstaging from M0 to M1, which was seen by MRI, was seen only in about 0.7% patients. That is, in less than 1% patients, and MRI actually upstaged the disease when after PET CT, which means that if the patient had brain mets, the patient was already metastatic elsewhere in the body. So actual upstaging to M0 from M0 to M1 was achieved only in less than 1% of patients by MRI. But importantly, MRI changed the status of the disease from solitary met to oligomet, or from oligomet to multiple mets in nearly 20% of the patients. So pure upstaging was done in less than 1%, but change of the status of the metastases is where MRI can be very useful. So to conclude, PET is a standard imaging modality. There is level 1A evidence, as we saw. There are randomized trials. It's part of most guideline recommendations, and it's primarily because of the ability of PET to detect metastatic disease. For nodal staging, PET has a limited accuracy. The negative predictive value is better compared to the positive predictive value. Positive predictive value is modest because in our country there is preponderance of granulomatous disease. for PET staging, we should remember that there are certain non-FDG concentrating regions like small metastatic nodules, ground glass nodules, pleural effusion, where PET may not show uptake and still the lesions can be metastatic. And in these cases, we need to rely on the CT component of PET for actually characterizing. And PET has a limited value for brain metastases, but now as we are moving to extended brain protocol using PET-CT, where we acquire a contrast enhanced CT scan of the brain, we can detect more and more brain metastases using a PET-CT. Thank you for your attention.